السلام عليكم ورحمة الله وبركاته. معكم الدكتور سالم الدويري. Today, inshallah, we are going to talk about CSF physiology, anatomy, and abnormal pathologies of the CSF. We will talk briefly about nerve conduction study and electromyogram, and we will go and talk about neuroradiology as an introduction for fourth year medical students. So to start with, let's review some important basic knowledge. So generally, as you all been taught in the last 3 years, the function of the CSF mainly is it acts as a shock absorber for the CNS. Also, it may serve as an immunological function that is similar to the lymphatic system in other organs. As you all know, there is no lymphatic system in the brain and the spinal cord, and the CSF it plays the role of the lymphatic system in other human body systems. Normally, the CSF is a clear fluid, no color, no odor. It has a specific gravity of 1.007 and a pH of around 7.33 to 7.35. Now let's go back to the pathway and the circulation of the CSF. 80% of the CSF is produced in the ventricles by the choroid plexuses. The main choroid plexuses that are responsible for the production of the CSF are located in the lateral ventricles and in the fourth ventricle. The rest, i.e., the 20% of the CSF, is produced intracranially, mainly in the interstitial space. Now, in adults, the CSF is produced at a constant rate of 0.3 ml per minute. This approximately is around 450 ml production CSF every day. Now, as we know that the total CSF volume in the central nervous system is 150 mils, so the CSF is replaced 3 times per day. Now, where is the CSF absorbed? CSF is absorbed mainly in the arachnoid villi, which is called also the granulations. These extend into the dural venous sinuses, mainly the superior sagittal sinus. Now, in contrast to CSF production, the rate of the absorption of the CSF in the arachnoid villi in the major venous sinuses is pressure dependent. And that means that when the intracranial pressure increases, the absorption of the CSF increases, and vice versa. Now, regarding the microscopy of the CSF, normally there is less than 5 lymphocytes or mononuclear cells in the CSF per millimeter. There should be no RBCs and there should be no polymorphonuclear cells. Now, if there is any polymorphonuclear cells, this is abnormal. If there is more than 10 lymphocytes, this is abnormal. If there is a 5 to 10 lymphocytes, this is suspicious of there's something wrong going on, most likely an infection. Now, how does the CSF circulate? Now, this is a diagram, a sagittal diagram of the human brain. So if we look here, this is the lateral ventricle at the pointer. Okay. CSF is produced by the arachnoid villi, which is colored in red as we see. The CSF in the lateral ventricles travels through the foramen of Monro here to the third ventricle. From there, the transmitted CSF, in addition to the CSF that is produced by the choroid plexus of the third ventricle, will go to the fourth ventricle over here through the aqueduct of Sylvius. From there, in addition to the CSF that is produced by the choroid plexus in the fourth ventricle, this will exit the ventricular system through either the foramen of Magendie or the two foramens of Luchka laterally to the subarachnoid space here, and it will circulate around the CSF, and there is the arachnoid villi, which secretes the CSF into the dural venous sinuses. And the other amount of CSF is secreted into the spinal canal to surround the spinal cord in the subarachnoid space. Now, as we know, in any time, there is 150 cc's of CSF circulating in our body. 50%, which is 75 mils of CSF, they are present intracranially. And the rest, or the other half, the 75 millimeters, they are circulating around the spinal cord. Of the 75 cc's in the intracranial CSF, almost 30 to 35 cc's, they are present in the ventricular system, the lateral ventricles, the third and the fourth, and the foramens. Okay. Now, as we said before, in an adult, there is 150 cc's in the human body, 50% intracranially and 50% spinally. The formation rate is around 0.3 to 0.35 mil per minute, and the pressure in centimeters in an adult it is around 7 to 15 centimeter of water. Okay, and in patients younger than that, it's around 18 to 20. Now, measuring the pressure of the CSF, either we measure this pressure, sorry. So either we measure it in centimeter of water or millimeter mercury. This is the equation how to convert any reading of the CSF pressure from centimeter water to millimeter mercury, or the other way of converting the millimeter mercury to centimeter water. Okay, now what are the characteristics of CSF normally and in other common pathologies? So in this table we see here the OP is the opening pressure of the CSF, the appearance, cells, protein, glucose, and others. Normally the opening pressure in centimeter water is 7 to 18. More than 18 is considered abnormal. As we said before, it's clear and colorless. There should be zero polymorphonuclear cells and zero RBCs, and up to 5 monocytes is considered within normal. 5 to 10 is suspicious. Protein is around 15 to 45 milligram, and the glucose should be around 50% of the serum glucose. Now, in acute meningitis, sometimes the opening pressure is increased. The appearance of the CSF due to the presence of bacteria is turbid. You should see, of course, increase in the number of white blood cells, usually polymorphonuclear cells. Protein will be high. Glucose will be less than 20% of the serum glucose measured. Environment meningitis, usually the opening pressure is normal and the appearance is similar to the normal CSF. White blood cells, mostly monocytes. The protein is not that, there is no a drastic increase in the protein level. The glucose should be normal. And in early viral meningitis, we see usually in the early course of the disease, we see polymorphonuclear cells, and after that, we see monocytes. Now, traumatic, what do we mean by traumatic TAP? Traumatic TAP is when you put a spinal needle in the spine of a patient, the lumbar spine, and you drain some CSF. So in traumatic TAP, when you insert the needle, you might injure one of the epidural blood vessels while you enter the needle. So this will lead to the presence of some RBCs and white blood cells in the CSF. So the CSF will appear bloody. Okay. If you send the CSF and centrifugate it in the lab, the supernatant will be colorless. The RBC to the white blood cell ratio is similar to that in the blood. The protein is slightly high due to the presence of the RBCs and white blood cells. The glucose is similar to the serum glucose. Okay, and what we mean here is if you take, for example, 3 tubes, you collect the CSF in 3 tubes, what you find is that the number of the RBCs in the first tube will be more than the second, and the second will be more than the third. So the number of the RBCs will decrease with time or with the drainage of the CSF. Now, in the subarachnoid hemorrhage, how can you differentiate that this RBCs is different, or how can you differentiate if these RBCs are due to traumatic TAP or due to the presence of RBCs due to subarachnoid hemorrhage? We will talk about that thoroughly in the when we talk about the subarachnoid hemorrhage. But in subarachnoid hemorrhage, usually the opening pressure is high. Of course, you will see it bloody, but if you send it to the lab for centrifugation, the supernatant will be xanthochromic. And what we mean by xanthochromic, after exposure to specific light frequency, it will appear xanthochromic, more toward the yellow. Okay, the presence of RBCs, protein will be high, glucose usually is normal. You might find it a little bit low, and the RBCs in the tubes that you collect is almost the same in tube number 1, 2, or 3. Okay, and the RBCs, yes, it will disappear after a couple of weeks after the subarachnoid hemorrhage. So now let's talk about nerve conduction study and EMG. So these are what people say about that these are تخطيط الأعصاب. Okay. So starting with the EMG. EMG is assessment of the muscles through a needle exam. Okay. We will not go through the details of how the EMG is done. The EMG is done usually by the neurologist or a neurophysiologist. The patient comes to the outpatient clinic, they insert specific needles, and they assess the muscles where the needle is at that muscle. Okay. So they measure just the electrical response of a specific muscle, okay, through that needle. Now, some hints, okay. Now, if you are happy with the examination of your patient, so what I mean by happy, if the patient is cooperative, is conscious, and you are um, satisfied with your examination, and the examination of the motor examination, of course, is reliable. The EMG usually will not add significant information. Also, when you have a patient with a normal motor examination, usually if you do an EMG, the EMG will be normal. So the question is when to use the EMG. So the best way to use the EMG if you have a patient who's having a motor weakness, but you are not sure where the lesion is. Is it at the nerve root? Is it preganglionic? Is it postganglionic? Is it in peripheral nerves? The EMG will help you to localize where the pathology is. Um, Common is common. One of the most common presentations in neurosurgical outpatient clinics is radiculopathy. Radiculopathy is pain uh, along a dermatomal distribution that goes with the specific uh, nerve root of that dermatome. Uh, Unfortunately, EMG in the first 3 weeks after the onset of radiculopathy due to, for example, more acute disc protrusion is not that sensitive or specific, and it needs around 3 weeks to help you in your diagnosis. Okay, now regarding the nerve conduction study, what's the difference between nerve conduction study and EMG? The nerve conduction study is a study of the conduction, sorry, of that nerve. So it evaluates the amplitude, the latency, and the duration of the motor and sensory nerves. Okay, it helps you to identify entrapment neuropathies that might mimic radiculopathies. For example, if you have a patient with a carpal tunnel syndrome, the patient will have symptoms mainly in the thumb, index, and middle finger. If you are suspecting that the patient might have C6 or C7 radiculopathy, uh, the nerve conduction study will help you in your diagnosis. Okay, so let's go now to talk about uh, radiology or neuroradiology. This is a very important topic. Uh, a, 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 a good neurosurgeon or a good doctor who consider himself as a good neurosurgeon or a good neurologist should be familiar at least with the basics of neuroradiology. So to start with, let's talk about the CT scan. So the CT scan mainly we have two modalities of CT scan that we want you to know. A non-contrast CT scan, okay, and an IV enhanced or a contrasted CT scan. A non-contrast CT scan uh, is often employed in the emergency situations to evaluate the bone and the presence of acute blood intracranially. Usually, you use it in head injury uh, cases to evaluate the bone. If there's an acute epidural hematoma, acute subdural hematoma, subarachnoid hemorrhage, contusions, also for the assessment of encephalus, which is the presence of air bubbles or inside intracranially. And also, commonly we use it in the assessment of patients uh, who's having a VP shunt, who's done a tumor surgery, etc., or present to the emergency department. The CT scan is excellent for assessing the bone, but the MRI is way much better than the CT scan in the assessment of um, uh, soft tissue pathologies such as strokes, such as uh, brain tumors, brain abscesses, and etc. Okay. Also, CT is not that reliable, if we can say that, in the assessment of the posterior fossa due to the bony artifact that might mislead you in your assessment. Okay. Uh, the enhanced CT scan or the use of contrast in the CT scan is primarily used in elective cases. If you are suspecting a neoplasm, if you are suspecting a abscess, a vascular malformation, um, etc. Also, in patients who have contraindication for an MRI, the only option is to have a contrasted CT scan. Now, Hounsfield unit. What's Hounsfield unit? Hounsfield unit is the measurement of how much X-rays can protrude through an organ. So the idea of a CT scan, the CT scan, imagine it as a huge multiple X-ray machines that radiates X-rays through the body. Every organ in the body, it will either reflect or allow the X-rays to pass through it, and this will give us the density or the Hounsfield unit of that organ. Okay, so the higher the dense of the structure that you are scanning, for example, bone will not allow the X-rays to go through it, though it will reflect the X-rays of the CT scan, and this will give the let's say the density of the bone to appear wide on CT scan. We will see later on more and discuss later in this lecture. So if we go to this table, for example, let's go here. So a dense bone, it has a Hounsfield unit of a positive 1000. It will appear white, and when describing any structure in the CT or MRI, we don't say white, black, or gray. When CT scan, we say hyperdense, or anisodense, or hypodense. So the dense bone will appear hyperdense. The air will appear dark, dark black. Okay, and the Hounsfield unit of it is minus 1000, and the water, the Hounsfield unit of water is 0. Okay, now in the CT scan, let's go here. So the gray matter, it has a Hounsfield unit of 30 to 40. The white matter is 20 to 35. Edema 10 to 14, CSF plus 5. It's almost like water. Bone plus 600, and etc. Now let's talk here about the gray matter and the white matter. So the white matter, it's white in our body, and the gray matter is gray. But in the CT scan, the density of the white matter is relatively lower than the gray matter. So the gray matter in the CT scan will appear brighter or more toward hyperdensity in relation to the white matter. We will see more scans there, and we'll discuss that. Okay. Another note here: hematocrit of less than 23% will appear as isodense to the brain. We'll talk about that later on. Okay. We'll see scans later on. Now let's go for. So the MRI, as we said before, it's way much better for the assessment of soft tissues in relation to the CT scan. Now, the MRI has more than one time, what we call it weighted images. Okay, what we want you to know here are the some frequencies of the MRI. The first one is T1, weighted image, so a T1 W weighted eye image. Another one is T2 weighted image and a T1 weighted image with contrast. Now, there's something called the time of repetition, TR, and time to echo, okay, TE. You will learn more about that when you take the radiology course. So, we have a short TE, long TE, short TR, and long TR. A short TE is less than 50, long more than 80, short TR less than 1000, long TR more than 2000. So, and these numbers, you will see it on when you look at an MRI. So a T1 weighted image MRI will have a short TE and short TR. So a short TE of less than 50. So if you look to an MRI and you see the TE and it's less than 50 and the TR is less than 1000, this is one way to differentiate between T1 and T2 weighted images. And contrary, the T2 weighted images will have a long TE of more than 80 and a long TR more than 2000. Okay, good. Now, let's talk more about the T1 MRIs. So the T1 MRI, as we said before, the CT scan, we say the white is hyperdense, the black is hypodense, the gray is isodense. This is like a ruler, or consider it as a color bar. Okay, so here is the hyper intense. So in the MRI we don't say hyper dense like in the CT scan. In the white, anything white we say it hyper intense. Anything that's black, hypo intense, and anything that is gray we call it, or we refer it as iso intense. So what are the things that will appear hyper intense on T1, and what are the things that will appear hypointense on T1, and what are the things that are in between? So the fats, including the bone marrow of the bone and blood, uh, which is more than 48 hours old, and melanin, they will appear white, i.e. hyperintense on T1 MRI. The other end, the CSF will appear hypointense, and also the bone will cause let's not go into details, will also appear hypointense. Okay, and this is one of the ways also to differentiate between T1 and T2. We'll talk about it in the next slide. Okay, now things in between. So the white matter will appear relatively, if you compare it to the gray matter on T1 MRI, will appear brighter, and the gray matter will appear darker. So the white matter in relation to the gray matter, it is hyper-intense in relation to the gray matter. The gray matter is hypo-intense if we compare it to the white matter, because it's darker. The CSF is hypo-intense in relation to the calcium or the gray matter. Okay. The fat is hyper-intense in relation to the white matter, and etc. Okay. Now, the T2 MRI. The T2 MRI, it's referred as a pathological image, and the T1 is referred as to anatomical image. Okay, what we mean by that, when you want to assess the pathology more, the T2 will give you details more than the T1. If you want to assess the anatomy, the T1 is better than the T2. Okay, now generally speaking, most pathologies will appear hyperintense or high signal on T2 weighted image, including, of course, the edema. Okay, now how to differentiate between T2E1 and T2? The T2, the CSF is hyperintense or white. It has a long TR, more than 2000, long TE more than 80. They are long. Okay, now let's go here. The same thing applies to the T2 weighted image. The brain edema, not the brain, the edema, the brain or the water, okay, will appear hyperintense on T2, also including the CSF. Okay, it will appear hyperintense. Now, the gray matter, in contrary to T1, will appear relatively brighter than the white matter. So we say it's relatively hyper-intense to the white matter. But the gray matter is hypo-intense in relation to the brain edema. Okay, forget this about this CSF. I think this is wrong. The bone and the fat the bone will still appear hypo-intense, but the fat will appear hypo-intense, contrary to the T1 weighted image where it appears hyper-intense. Okay. Now, let's go about contraindications for MRI. Contraindications for MRI: any metal that is inserted in your patient's body that is not compatible with the MRI. For example, cardiac pacemaker or any defibrillator, any implanted neurostimulators or any cochlear implant that is not compatible with the MRI. Infusion pump, for example, baclofen infusion pump or analgesia infusion pump, morphine infusion pump, and etc. Ferromagnetic aneurysmal clips that were used previously more than 15-20 years ago in our area. They are ferromagnetic, so you can't uh, do an MRI for a patient who has a ferromagnetic aneurysmal clips. These clips nowadays they are MRI compatible. Uh, any metallic implant, okay, that is mainly composed of iron or cobalt, okay, and Swan-Ganz catheter, which are the pulmonary artery catheters, metallic fragments, um, placement of vascular stent, coil or a filter in the last 6 weeks, and a sharp nail, and relevant contraindications, which is common, is claustrophobic patients. Claustrophobic patients are patients who are afraid of being in a closed space, okay, in a closed room, in a machine, to have a scan, etc. So your role as a doctor is ask your patient, take a proper history in his past medical and surgical history. Any concerns, just contact his physician, ask him about uh, the metal that you are concerned about, have a report from him that this is either an MRI compatible or MRI not compatible. Any concerns, don't do the MRI. Okay. For patients who are claustrophobic, either you give them any diazepams, any anxiolytic. If this works, it works. It doesn't work, sometimes you have to do the MRI under general anesthesia. So now let's speak now clinically. Let's have yes. So here now, first of all, you should know what we mean by a sagittal cut, an axial cut, or a coronal cut. So an axial cut, this is a cut that goes from superior to inferior or from inferior to superior, as is shown in these two scans. Now the coronal is a cut that goes from anterior to posterior, and the sagittal is from medial to lateral, lateral to medial, or you can say right to left or left to right. So here let's uh, uh, say this is how an axial cut looks like. So this is an axial cut. Now we need to decide, is this an MRI or a CT scan? This is a CT scan. Why? Because as we said before, the bone, this is the skull bone, okay, around the brain, okay, and these are the frontal air sinuses, okay. حكينا بالأول إنه الهاونسفيلد unit of the air is -1000, so it should appear on the CT scan as hypodense, very black. Okay, there's a hint. The air or the atmosphere surrounding your patient here is hypointense and the hypodense, sorry, and the density of this area is similar to the air around the patient. So this is air, and the only area normally of air in the bone in this area is the frontal air sinuses. Now, so let's agree that this is a CT scan. Okay. The second thing you should decide, is this an IV enhanced CT scan or just a plain CT scan without contrast? If you look at the right hand side here is how a CT scan with IV contrast appears. So if you look here, there are some small hyperdense dots. Here's a dot, here's another dot, and some streaks of hyperdensity areas here and there. There's one, there's another one here along the gyri. Okay, so these are the blood vessels where the contrast runs. Okay, and as you may know, the contrast appears hyperdense in a CT scan and an MRI. Okay, so this is how a CT scan without contrast looks like, and this is how a CT scan with IV contrast looks like. So here, if we look here, this is the gray matter. Okay, this is the white matter. So gray matter, white matter. This is the left frontal horn of the lateral ventricle. This is the body of the lateral ventricle. This is the frontal horn of the right lateral ventricle. This is the body of the right lateral ventricle. This is the foramen of Monro on the left side. This is the foramen of Monro on the right side. Okay, here is where the occipital horn of the left lateral ventricles, and here is the right. It's not obvious here because it's not through the bulk of the occipital horns. Now, what are these two hyperdense structures that present in the occipital horns and present bilaterally? These are a calcified choroid plexus in both occipital horns of the lateral ventricles. Normally, these might calcify, yes, and you can see that there, calcified choroid plexus, calcified choroid plexus. Okay, good. So this is the right side, right cerebral hemisphere. This is the left cerebral hemisphere. Okay, when you look at the scan, you see a scan or an MRI of the brain, cervical, chest, abdomen, pelvis. Imagine that you are looking at the scan as the patient is lying supine and you are standing on his feet side and you are looking at him. So this is the right side of the patient and this is the left side of the patient. Okay, good. So this is a coronal cut, a CT coronal cut without contrast. We see no contrast in the blood vessels here or there, mainly in the gyri. Okay, this is the basilar artery with lateral ventricles. Okay, here is sagittal cut as well. Okay, bone, gyri, corpus callosum here, third ventricle in this area. Okay, this is the cerebellum, tentorium cerebelli. This is the fourth ventricle. This is the midbrain. This is the pons, the oblongata, cervical spinal cord. Okay, another CT scan, and talk about another modality of the CT scan, which is CT scan bone window. So if you look at the CT scan, this one is called the CT scan brain tissue window. This is CT scan bone window. What's the difference? In the bone window, you see only the bone. You see the outer cortex, the inner cortex. You see no brain tissue, no ventricles, no CSF, nothing. Okay, the only thing you can see is the bone. Is the bone. Is the lambdoid suture on the right side, and lambdoid suture on the left side, coronal suture here, coronal suture here. Okay, this is frontal bone, parietal bone, occipital bone, and etc. And why we use the bone window in addition to the brain tissue window or the soft tissue window? The bone window is used to assess the bone. As you can see here, you can see the details of the bone. Here you can see the outer cortex, the outer table, and the inner table, and etc. Any linear fracture, for example, or any bony pathology, you can see it here, but easily you can miss it there. And don't ever forget, any patient with history of trauma, look at the brain tissue window and the bone window. Okay. Now, let's go to the MRI. As you can see here, there's a big difference in the details of the brain tissue between the MRI and the CT scan. Now, so the soft tissue details are way much better. The bone in both T1 and T2 MRI will appear hypointense, or what's called a signal void. So this is the bone. This black circle that I'm pointing at is the bone. And the thin white layer is the scalp layer, mainly the fat tissue. Okay, and here's the brain. Now, so this is, let's agree, this is an MRI. This is an axial cut. This is a sagittal cut. Okay, now, where's T1, where's T2? Look at the CSF. So, where to look at the CSF? Look in the ventricles or in the subarachnoid space, as simple as that. The ventricles, lateral ventricles, third ventricle, occipital horns. The signal of the CSF is high. So this is hyper intense. It's white. So this is a T2 weighted image. Here, this is sagittal cut, T1 weighted image. CSF inside the subarachnoid space, in the gyri is black, low intensity, low signal. So it's hypo-intense. So this is a T1 weighted image. Okay, the CSF in the fourth ventricle here is hypointense. The CSF in front of the midbrain, the pons, the oblongata, and along the way here is hypointense. So this is a T1 weighted image. This is a T2 weighted image. This is a sagittal cut. This is an axial cut. This is the right side. This is the left side. Here, this is the anterior side. This is the posterior. You can't decide if this is the right or the left, except you have, unless you have a what we call a scout view here, which gives you where you are or which side you are looking at. Okay, and you will have a neuroanatomy radiology based lecture later on. Okay, now the last thing, or the last topic of today's lecture is the radiology of the blood vessels. So as we have a CT scan of the brain and MRI of the brain, we do have a scan of the vessels. Either we scan the veins or the arteries. If we are scanning the veins, it's called a venography. If we are scanning the arteries, it's called arteriography. Okay, now, if you want to have a look radiologically to the blood vessels, either you use an X-ray or a CT or an MRI. That's it, as simple as that. Okay, now what we are looking at here is um, venography. Here arteriography. Now, what are we using in this scan? We are using the MRI. So this is called an MR venography, and this is called MR arteriography. Okay, here we can see superior sagittal sinus, inferior sagittal sinus, not that clear, transverse sinus, sigmoid sinus, and etc. Okay, we're not asking you to know that how to read an MR venography, but at least when you look at it, you know that this is a MR magnetic resonance venography, and this is the MR arteriography. Okay, for example, this is the middle cerebral artery, this is the anterior cerebral artery, and etc. This anterior cerebral artery, and these are the branches. We're not going through the anatomy, we're going through radiology. Okay, now how about the arteriography using the CT scan? So this is how the CT angiography or the CT arteriography looks like. CT scan There's a bone, hyperdense. Here you can see the internal carotid artery on the right, on the left side, basal artery with branches on the right and on the left. This is sagittal view. Here you see the anterocerebral artery, the pericollosa and the callosal marginal arteries, a branch of the basal artery, and etc. This is CT arteriography. This is scanning of the arteries of the brain using a CT machine. Okay, good. Now the last modality of angiography is the digitally subtracted angiography, or what is called a conventional angiography. What is that? This is a angiography using an X-ray machine. Okay, as the previous CT angiography, the interventional neuroradiologist will insert needle and give the contrasts and one of the four major arteries of the brain. Okay, and he will have an X-ray. Now, why we say it's a digital subtracted? Subtraction is removal of something digitally using the software. So here he gives the contrast. The interventional neuroradiologist will give the contrast, and he will take out. He will subtract the skull shadows, so you can assess the arteries. Okay, so as you might see, here are the skull shadows. They are subtracted, and you can see and assess the major arteries here and the branches. Okay, good. So this is basal artery branches, cerebral artery as well. Okay, good. Think we are near lecture. Yes. Okay, thank you for listening. Please don't hesitate if you have any question during the clinical rounds. And good luck to all of you. Thank you.